My name is Sue Ross, and I am with St. Vincent Hospice, and I'm a chaplain, so I don't have all the medical answers, but certainly I can bring some information, and I have sort of a hodgepodge of things, and then we'll welcome any questions at the end as well. Hospice, I absolutely love hospice care, and I feel really called to do this work. And Cicely Saunders was the founder of modern day hospice. Hospice care, sort of the theory of hospice care, happened from the very beginning, in the early days of life, as people cared for their loved ones as they were dying. But Cicely Saunders was in London, and I can't give you a biography of her, but she's well known in the hospice field. And one of her statements that has always stuck with me is that what we do in hospice is to help people live well until they die. And that is the purpose of hospice. And there's sort of a misconception about hospice sometimes. People think that it's only at the very end of life. And that's sort of the common feeling about it. But we hope to get patients that are not at the very end of life, but that we can help them figure out how to live well, and controlling pain and some of those kind of things. And so that is our purpose as we work in that. Hospice care, there's some criteria, and one is that the prognosis, you have to have a diagnosis that has a prognosis that in a standard, sort of the average procession of the disease, you have 6 months or less to live. That's a standard, that's an average. So not everyone, follows that. But if you quit trying to cure something and you have a certain disease, a cancer or a COPD or all kinds of things, if you're not going to treat it, and the doctor can verify and state that a normal procession of the disease would be life for less than 6 more months, then you qualify for hospice. Now we have lots of patients that even graduate, we call that graduate, from hospice. They get into hospice care and their pain gets controlled. They figure out what medicines they need to control that pain, and they thrive. So we definitely have patients that, sort of graduate. What happens with hospice is that there is what we call certification periods. And so when someone signs in to hospice, there's a 90-day certification period, and the doctor has to do a sort of a face-to-face visit, make sure that you meet criteria. And then after that, then there's a second 90-day certification period. And then if you're still sort of meeting criteria, meaning you're declining in some way, sometimes it's just weight loss, it may be minimal changes, but if you're sort of declining a little bit, then you would continue to be eligible for hospice care. And then after the 90 days, then it becomes 60 days. So every 60 days, you have to be what we would call recertified. So that's sort of the pattern that it works. Hospice has 4 different levels of care. One, sort of the highest level is continuous care. There are hospices that provide that. I'm sure in Indianapolis, our hospice does not provide continuous care. We have also a GI level, sort of a general inpatient level of care, and we have an inpatient unit at our hospice that our GI patients would go to. So we have a beautiful facility. If you've never been there, sometime you ought to stop by. It's on Payne Road off of 86th Street, but it's a beautiful facility, and it's a place of great sacredness and peace. And so I do encourage anyone to stop there if they have questions or want to see that. There's also a respite care in the inpatient unit that people can go for caregivers that need a break. It is hard work being a caregiver. And so sometimes the patient, the caregiver is giving such extreme care and they're just worn out. And so they need a break. So the patient might go to the inpatient unit for 5 days. It's a 5-day respite. They can go and take a break, let the staff there, our wonderful nurses, we have a wonderful nurse here with us in the back, but go and let the nurses take care of your loved one. And you take sort of a break, self-care for yourself, and then the patient would go back home or wherever they would be. And the last level is just called routine care, and that's most of what we do is in our home care. So a patient might be in the home, they might be in a facility, and it's just routine care. Our hospice nurses, chaplains, social workers, volunteers, aides, we all would go out periodically and care for someone in the home. And there's a plan of care that's always established, and so we might go twice a week, we might go once a week, we might go once a month. It just depends on what the needs are and what the desire would be. So those are the 4 levels of care for hospice that from the high level. Let's see. Something that I had wanted to try, or something I do a lot when I do these kind of talks, is an exercise, and I thought with just the logistics it was going to be a little cumbersome to try to do it with so many and you're eating lunch and all those things, but I want you to think about it just in your mind. Think of 3 things, 3 people, or even groups of people. If you have 3 kids, you only get to list just kids. Don't say names, and you're just doing it in your mind, but 3 different categories or people that you love. Just sort of bring those to mind for just a second. So 3 people that you love, 3 categories of people that you love. Another would be 3 categories or roles that you play. Your husband, wife, partner, spouse, whatever the term, uncle, friend, parishioner, any kind of role. 3 of the important roles that you have in your life. 3 things that build you up and bring you joy. So sort of think at that. Excuse me. And then 3 things that you love to do. Just 3 things you love to do. And we could do more of those categories, but this will give you a gist of it. That if you put those sort of out in front of you, and I tell you, you have to take one away, that you don't get that anymore, then try taking one away. I'm not going to really make you do it, so it's okay. Just sort of experiment with the feeling around that. Okay, and then I'm going to come up and I'm going to take one of those away from each of you. So you have no control which one I'm going to take. I just am blindly going to take them. And then you turn them over, and then you have to take one. So you don't know which one you're picking. So sort of, again, just to sort of experience what that feeling is like. And that can be what it feels like for a hospice patient. They're losing things, they're declining, they're losing things along the way, and so it is hard stuff. You lose control, you lose what you have loved to do. And families then are watching that as well, and so they're losing along with that. And so it becomes a really difficult situation, and that is why Cicely Saunders, when she started hospice, she was insistent that social workers and chaplains had to be part of the team. And so we are grateful for Cicely Saunders. She was a social worker, she was a nurse. I think she actually was a doctor at one point as well, but she was a social worker as well and had a really strong spiritual background. So she had like all facets, body, mind, and spirit. But I am grateful for her because it allows me and others to be able to sit with patients and families as they go through some of these really difficult pieces of life. Referrals, like I said, so I have a hodgepodge, but referrals can come from a lot of different ways. We, right now, are associated with a hospital, of course, St. Vincent, and so we get referrals from the hospital. People go into ER, they had a stroke, and you know, something needs to happen for them, and they are not going to live long, and so they might the doctor there might refer them to hospice. Intensive care patients, cancer patients, all kinds of referrals can come from the hospital. We get referrals from individual general physicians that are working with their patients, you know, inviting them to be a part of hospice. And it's a hard dichotomy because doctors are trained, I mean, they go to school to cure, they learn how to cure, and so it's really difficult for that process to happen. And some doctors do it with such grace, but it's not easy, you know, when you know, sort of change from what hospice care is. It's comfort care from curative. So we go from a curative, and another word that you would hear is palliative. So you go from trying to cure whatever you have. If you have cancer and you're doing chemo and radiation and experimental drugs and programs, and you know, there's all kinds of things that can happen. If you go from that and say, I've had enough, and you move to palliative, which is comfort. I don't want to fight, I want to enjoy the time I have. And that's why, you know, live well until you die. You know, it's this culture of that it's okay to enjoy life until you die. We're all going to die. And so, you know, where's the comfort level? And I'm sure that there's been some really good conversation already, and probably will in the future, because it is a lot about culture and society beliefs and your own internal struggles. So there's a lot of things. And so again, proud that in hospice we have social workers and chaplains that really help facilitate that. I just had this in my car because I take them out. This is a really common book for hospice programs. You can go to any hospice. I worked at a hospice program initially in Florida, Suncoast Hospice, one of the largest in the country. And they use this book. I get to St. Vincent, they use this book. And I'm sure if I went to many hospices, they would use this book. But it's called Gone From My Sight. And what it is, it's just a small book, but it is full of really powerful things. It talks about sort of the physical process that happens. And I'll just read a little bit. So and it's just a general, everyone has their own timeline. But a general thing, 1 to 3 months. Someone that's dying would start to withdraw from the world and sort of people. They decrease their food intake. They increase in their sleep. They go inside their self. They're less communicative. 1 to 2 weeks, mental changes may happen. They get disoriented and just agitated. And then there's physical changes, of course. Blood pressure may decrease, pulse increases, respiratory irregularities, congestion, so lots of those kind of things. And days and hours, sometimes, and you probably have heard, there's sort of a surge of energy, and that can happen as well. It doesn't always, but it can. The eyes get sort of glassy and teary, and if you are with someone, if you've been with someone that has been dying, a lot of times they are looking beyond us. And I always think they are looking to whatever your theological beliefs, and I'm in a Presbyterian church, so you probably have some kind of faith belief, but if you believe in the afterlife, I say I can't do this work without believing there is something bigger than myself. I have seen patients ask me if I hear the music. There's no music. I've seen them shake hands with people that I can't see. I have seen a Muslim patient raise his arms and say Allah, and then immediately die. There's lots and lots of those kind of stories that happen. And so that sort of that process starts to happen. An analogy or metaphor that sometimes I use is that dying can be sort of like labor. It is a labor into your eternal life. And so everyone does it differently. Just like women have different kinds of labors. Some labor for hours and hours, and some very few, and some are painful, and well, they're probably all painful. But anyway, but there's different ways to labor, and I think that people that are dying are going through that same kind of process. They're laboring into their eternal life. Many times you'll see people pick at their clothes, pick at their skin. They don't want clothes on. Now, I can't tell you for certain what that means. You know, I have no insight into that, except the belief is that they're starting to separate from their body. Their spirit is starting to separate from their body, and so the skin, the clothes are not necessary. Like I said, I can't tell you that is a fact, but it's certainly the belief in the hospice world. I see it all the time, and we see people doing that right before they die. So I wanted to talk just a little bit about sort of my role. And, you know, one of the things as a chaplain is I want to meet people where they are. And so I encounter many different situations. You know, some family members are worried about the loved one's salvation. They want to, you know, ensure that. They are worried about families, you know, family members. If there's dysfunction in family, then it multiplies at a crisis like this. So there's lots of different things that I do, but a main question that I usually ask a patient, and again, earlier, I love getting patients that I have 6 months or more with, because then we can have some important conversations. But what is it that you need to do to feel like you have finished life well? And so that's one of the questions that I ask them, but I also ask that of my friends, and I ask that of you, you know, to think about what is it that you need to do to feel like you have finished life well. And I don't care if you're 30 and healthy, I mean, isn't that how we want to live, that we are going to be able to finish life well? And when God says, good and faithful servant, that we feel that too, you know, to some extent. So that's a conversation that I have many times with patients about that. Sometimes people will talk about needing to reconcile. We had a patient on the inpatient unit. It's probably been, I don't know, 6 months ago, and I had asked her that question, and she said, quickly, actually, she didn't have to think very long, but she said, I need to reconcile with some people. I've treated people poorly. And so she did. She had time. She went home, and she had a time of reconciliation with many, many folks. And her husband came back after her death, and you know, and described great gratitude that she was able to do that, and the people that she had made restitution with were, you know, at peace. And so it was, you know, a wonderful way for her to sort of finish life well. Sometimes there's, you know, forgiveness that needs to happen. Sometimes I help people with helping a family member understand decisions. A patient who has been on dialysis for years and years and have other complicating factors get tired, and they've had it. They have been living it, and so they have been hearing God speak to them in whatever frame of reference that is for them. Sometimes people don't call God God or name that, but my own belief, and I'm not here to preach, but my own belief is that God is working in their life as they are declining in some way, and so God helps them adjust. And so the patient sometimes comes to that realization before a family member, because the family member is the one that is going to experience the physical loss. The patient has a win-win situation to some extent. If it all goes well, they're with their family, and if they die, they're with God, and as they adjust to that, they become more peaceful about that. So part of my role is to sort of help families, come to accept that too. And it's hard. There's a physical loss to it, which then leads me to another thing that I feel like I get to do is help people really hold complex feelings, especially people of faith. And if a patient's been suffering and in pain and those kind of things, families may rejoice that they are now with their Lord and Savior and out of pain. They may hold that and mean it with all their heart, but there's still a physical loss that's very sad and very disruptive and all those things. So I talk a lot about holding complex feelings, because that's what we do. That's what we do as human beings. We have complex feelings, so it doesn't fit neatly in a category at all. And so that's part of the hospice work, I think. I just had wanted to tell 2 or 3 stories, sort of short stories, but just to give you a sense. I worked with a patient when I was in Florida, actually, and his name was Ricky, and he was a humanist. I didn't know one thing about a humanist. When I met him, I didn't know. I mean, I had heard of it, but I really did not know much about that. And so I was always intrigued, and I sat with him and listened to him tell me why he was and what that meant to him. And it was just, I learned so much from him, and he still really holds a special place in my heart. But I went to see him. He was in the hospital, and I went to see him, and when I got there, he had been discharged. So I called his significant other, wasn't married, but had a significant other, and said, I didn't normally do this because it wasn't really normally part of my role. But I said, would it be helpful if I stopped by your house? He said, oh, yes, please come. And so I did, and I think her name was Jean, I believe. And she said, I haven't been out of this house for a while, and Ricky was very restless, so he was agitated. He was picking at clothes. She said, I really need to walk down the street into the convenience store and get me a pack of cigarettes. Would you stay with him? He was up, walking around, drinking water. He was very confused and hallucinating, but nevertheless, he was up. He was a big guy, and so I was a little afraid. I'm a big girl, but I didn't think if he would fall, I was going to be in very good shape. So I was a little nervous about it, but of course, go. So she walks out. She's probably gone 2 minutes, and he lay down on the bed and died. But I believed all along that he knew 2 or 3 things. One, he knew he wasn't going to be alone without Jean for a long time. The situation was going to be that she was going to be there. He trusted me, and so he picked his time. He chose his time to lay down and go, even though it didn't seem like it was time. But for him, it was time. And again, we see that kind of stuff all the time. There's a mystery to it. I can't tell you any facts about it, but I do know that it is very obvious that people go when they want to go, and that sometimes it's when everyone comes, and sometimes it's when everyone goes. And I can't even tell you why one would pick one over the other. Sometimes the most introverted people want everyone to be there, and the extroverted want them all to be gone. So there's no explanation, but it happens, and it's real for sure. But anyway, that was the story of Ricky. The second story is about a woman that had some conflict with her mother, and the patient was only 50 years old, thereabouts, and she had a rough relationship with her mom, and but her mom was very, as you can imagine, very upset that her daughter was dying, and she had always wanted to do things with her daughter, and her daughter just had sort of pushed her aside because they just didn't relate very well. Well, during this time, she was in the inpatient unit for a while, and then I would see her in the home. But during this time, again, I think God was working, helping them adjust. But they really came together, and they did some beautiful artwork together. And so before, at the end, I have a print of one of the pictures that she had done, the daughter, the patient had done, but the mother had worked right alongside of her and done some drawing as well. And so it was such a time of sacredness and holiness that happened in reconciliation, and the mother was able to feel like she found some peace, and the daughter finished life well. And so those are the kinds of stories that make me know that this is the work for me, and that I absolutely love it. Let's see. I saw a question on one of the things I think that you had given me, that there had been questions about how to talk to the dying. And so that struck me because I do that all the time. And one thing I would say, I don't know if anyone else has answered that question, but I'll answer it for me, is to be honest. I can't tell you again how many times a patient will say, "Don't tell my wife that I know that I'm dying," and then the other way around, they're both saying, don't tell, and they both, everyone knows, so don't, it's not an elephant in the living room, If you're gonna finish life well, you have to know what it is you need to do, and with your wife, or with your husband, or with your friend, or with your nephew or child, or whoever it is, all of them, if you don't talk about it, you will not finish life well. You will not do that. And so I encourage, if you are in those kind of situations, to be honest and not to be afraid to talk about dying. It is a circle of life. It is part of life, and it really is a completion of a beautiful life lived. As I mentioned before, I encourage people to sort of hold that complex feelings. It's okay to cry. It's okay to be mad. Shake your fist at God. It's okay. God's big enough. God can handle that. I think in holding those complex feelings, that person will find peace. And so as a caregiver, as a loved one, as a visitor in whatever capacity, if you can sort of hold that complex feeling with them, that it's a good thing. I think that in the most part, you would be there, depending on your role. I'm sort of talking generally about all of that, but you're in the role of making this journey with them, whether it's a moment in time or if it's over the course of many months. You are with them in the journey. And so what's that look like? And so if there's something that is tugging at your heart that you want to know from them, ask them. Because I think that is God helping you be a part of the journey, and you helping them be to know how the journey is going. I think that God puts all of us in those places that we can be the face of God and help people adjust to their eternal life. The thing that happens sometimes is, I always, to back up, I think it's always helpful for loved ones to sort of give permission when it's at the very end. And I know that the nurses and doctors can tell you when it's sort of at the very end. This book sort of helps guide that. But when they're at the very end, I think it's really important for loved ones to sort of give the permission. It's okay. We are going to be okay here. Yes, I'm sad that you're going, but I will be okay. And I think those words are really important to those those can be really hard words for loved ones to say, but it's really important. And I know that I had been asked to go into a room of a family that just was having a really hard time saying that. And so went to the bedside. There were two loved ones. I think the spouse and a daughter was in the room, and I sort of led this blessing. Thank you for your life. Thank you for the gifts that you've had. We're sad we're letting you go. God's holding you, and whatever I might have said. And then the spouse went to the bedside and said something. I'm sad, but it's okay to go. And then the daughter did the same thing. And then we left the room, and the patient then died after being really restless for quite some time. And it was those words, I know, that really helped them. And it was encouraging for the loved ones, because they know they said goodbye. And again, how to finish life well. If you as the caregiver and the loved one, you have to finish this well too. And what's that mean for you? If you want to make sure that they know that you love them and that you are sending your love with them, then tell them. And so all of that is sort of true. The thing that can happen is when at the end, loved ones really have a hard time with letting go. And so they'll say, it's okay to go, but then they're like right there, can you hear me? Can you hear me? Or squeeze my hand, and those kind of things. And it's one of the biggest gifts that you can give is to be able to step away a little bit and say, it's okay. I give you to God, or whatever the words might be, and then to sort of step away. Doesn't mean step out of the room necessarily, but it means to back off a little bit and give them some space so they can let go. Because think about yourself. If you are going to, if you're dying, let's just say you're dying and your spouse is right there saying it's okay to go, but you're right there, do you think you'd want to go? No, you're not gonna. I mean, at some point your body tells you, you have to, but if you have still fight in your spirit, then you don't want to go if that's happening. And so the biggest gift that you can give someone is to sort of step away and say, I love you, and let that go, and let them go. Let's see. The only thing that I have still on my list is about bereavement. Hospice programs are required. We're privileged to be able to do it, but we're required by regulations to have a bereavement program. So bereavement programs last 13 months for hospice, and that's for all family members. We at St. Vincent, we have grief counselors and a department of bereavement that then will follow our loved ones, are bereaved, and they can do one-on-one meetings. They can do, we have groups, like there's a group that I always think is powerful. It's a daughter's grief. So, so if you have a mother that, has died and you had a special relationship, which, happens a lot, then there's a special group for that. There's just grief 101 types of, to sort of help you understand grief. And so we have those groups. A group that started probably a year or so ago is one that I would love. It's about grief through the lens. I forget what it's called. But they do photography. And so they sort of experience their grief through photography. And some of the photographs that we have down our hallway from that group is just really phenomenal. And so there's lots of ways to sort of walk through grief, or walk in grief, not through, but walk in grief, that we can help with. So I think that first of all, I need to take a break from talking for a minute, but I would just open it up if there's any questions. Yes, I'm sorry.
I had kind of a misconception about the hospice, the inpatient hospice at St. Vincent's.
Mm-hmm.
So could you maybe explain, the inpatient hospice facilities, that would not be for the 3 months or the was 6
Right.
months or anything like that. And I think that's, maybe if you could go over that, I think that was kind of a misconception
Okay.
on several instances when I have had a death.
Okay. First of all, I think that one of the things that makes all that confusing is there's been a lot of changes through the years. It used to be that you could go to that facility and just stay for a long period of time, but because of all the Medicare changes and all the different healthcare changes, that's no longer the case. And so it's a place, it's sort of the emergency room of hospice. So it's an acute care facility. So the only way, thanks. The only way that you really can stay in the inpatient unit is that GI level of care. So you have pain out of control, you have symptoms out of control, and that they can't be managed at a lower level of care. So they can't be managed at home. But once the pain is back in control, thank you very much. Once the pain gets controlled and the doctor's worked out like what the medication should be and all of that, and they really can do it at home, then they have to leave the unit, which is difficult for all of our staff as well. We don't want people to have to leave any more than they want to leave usually, but it's part of the regulations, and so that you can't just stay there just to be staying there. So you have to be a GI level of care, which is the acute level. And there's criteria, I'm not that familiar with all of that, but, or you can have a respite stay, which is 5 days. And so that can happen as well. And so it has changed through the years, and that definitely has led to, confusion in the community about what the inpatient unit can and can't do. It's also, another thing I think that happens is when people are admitted to the inpatient unit, they're really bad. They are at an acute level, and so we don't know what direction that's going to go. They may die within a few days, or they might stabilize. As I talked earlier, people thrive, and so maybe they'll get the right different kinds of medicine, and that they'll sort of rebound a little bit and get stable. And so the people that are, the admission of it, we would have never thought that part, and so I think, we can always be clear of what that would happen in that.
Can you just talk a little bit more about the kind of the philosophical distinction between this curative care and how the palliative care, the comfort care really is a different approach, and what kind of a practical way, what that actually looks like? Yeah,
curative care is going to be doing, really, it can be anything. It can be, you're doing cancer. You don't have to have cancer to be in hospice. Sometimes that's a misnomer as well. It can be a lot of different diagnoses, but I'm going to use cancer. So if you have cancer, then you might be doing chemotherapy, you might be doing radiation, you might be in a trial program. You're doing something hoping to get to remission or maybe even cure. There's some that might even be hopeful in some situations that you're going to get cured, but even if you're just hoping to get to a remission. So you're doing things actively to get to a different spot, then that would be considered curative. But then the comfort is you're not doing anything that's going to change the trajectory of the disease. Curative, you're trying to do something to change the trajectory of that disease. So comfort care is more about pain control, whatever symptoms you might have. There's medication. We have lots of different medications that are used in hospice care that may or may not be common in other areas, but they work for anxiety, or they work for pain or symptoms, breathing. So
my husband died in home hospice. Could you comment a little bit about that? I mean, I experienced it, but unless I missed it, I probably, you didn't mention it before. He knew he was dying. It was his choice to say, I want to die at home.
Yeah. The home care is the routine level of care that I talked about, but I wasn't clear about how that exactly works. So thank you for bringing that up. We have home care. We have many, many patients that we service in the home. Hospice is not a place. Hospice is a service. And so we go to the home. So we have nurses that would go out, for example, I mean, a plan of care can look differently, but a sort of a standard plan of care would be a nurse would go out twice a week. An aide might go out twice a week to help with bathing and those kind of things. The chaplain might go every other week. A social worker may go every other week or every week if there's a lot of needs or those kind of things. And so there's a whole staff of people that go out into the home to provide hospice care. Does that answer?
Well, it does, and I think they're available 100%.
They are. It's a 24.
They're just not every day. You have the schedule.
Right. It's a 24/7, 365 service. And so there's always a chaplain on call, there's always a social worker on call, and of course there's always nurses and doctors that are available. So yes, and that becomes really, if in the middle of the night someone starts not breathing very well and you are anxious and you don't know what to do, you can call the on-call staff and say what's happening, and then they can tell you if you have some medication that would be helpful and those kind of things. That keeps you from going to the hospital, to ER, to the ER. I mean, I didn't really talk about this either, but you can have most hospice patients. We encourage hospice patients to have DNRs signed, do not resuscitate. And so the goal would be that you would stay at home and you're not going to get transported to the ER and everyone, poking and prodding you. I mean, that was a choice you had tried to make, and so we try to respect that. I mean, we do respect that, and we can help with that because we can give you medication that would help whatever symptoms are happening. And that's when, if the symptoms are just totally out of control and I tell you to take morphine and nothing happened, we could take you into the inpatient unit. That's the acute setting. That we could do that. Now there's many patients that they want to die at home.
This was choice.
Yeah. And so we do everything we can to help that happen.
Sue, would you address the financial side of the in-home care? And when one is living, my mother-in-law is going through failing health very markedly right now. And she doesn't want to move from that location, but where she lives does not accept Medicare. And so how is hospice paid for?
Well, I am not going to be very much of an expert on this at all, but I can tell you a little of what I know. That I mean, hospice is a part of a Medicare benefit. Hospice care, not room and board, but hospice care is part of a Medicare benefit. It can be paid through individual private insurance for people that are younger than it can be part of Medicaid if we're at that level. Where I know that we end up with problems is someone comes from the hospital and they don't have Medicare, they have a private insurance, or even if they have Medicare, it could even be Medicare, and then they don't need the GI level of care anymore and they have to go somewhere. Family can't take them home because they just don't have what they need to be able to care for someone at home, and so they have to go to ECF, extended care facility. Then hospice is only, the hospice benefit's still paid, but the room and board is not, and that's where people really get into problems. You can also pay, there's lots of groups around that you can pay for staff, private staff, to come into your home, but they're very expensive as well, and so money becomes a really issue. And I know I'm not really answering that because I don't really know, but I can get you an answer if if that's something that you would like. I'll be glad to do that.
Do the 6 month guideline apply to home care, hospice home care also?
Yes, it's hospice services. So keep in mind, and let me tell you, the staff has as much trouble as you might too. Hospice is a service, not a place. And so the hospice program mostly that I was describing applies to all of hospice. I mentioned the inpatient unit some and home some, but it does apply to all of hospice. So yes, it's a 6-month prognosis for all of hospice, whether you're at home, facility, inpatient, wherever you are. If you're signed up on hospice services, then there's a prognosis for the average disease process to be less than 6 months.
So a person can be, the possibility of a person dying within a month or 2 or 3 months. That recognition can be there, but if that person doesn't die in 3 months,
They're still,
but still can die at any time,
yep,
they can still continue receiving
they can.
the hospice
It's
care as long as that.
as long as they meet criteria is what we would, that's sort of the term, that as long as they meet criteria. And so there's a 90-day certification period to start with. And so for that 90 days, you don't have to really worry about what's happening. You're in hospice and it's all good. So then in 90 days, then there'd be a second certification period. And then somebody's making, the doctor, the nurses help, but they're making a determination if you still meet hospice criteria, meaning it still would look like normal progression of this disease without any curative treatment. You would still be going to die in 3 months at that point. And then at the end of that 6 months, it's still possible. You're still, you've lost 1 pound, 2 pounds, you're breathing a little heavier, those kind of things. You still could be even doing well, but you meet criteria. And so you could then we have people that are on the program for 2 years, 3 years even. So there's not anything that says you can't be on the program. You just have to meet criteria at the certification period.
Others? Yes.
An inpatient unit. My name is Connie. I'm working at the inpatient unit. So when you have a question regarding the respite care and the GI, there's another level. They call it on-site care. I don't know if you.
I know about it. I just
Okay.
didn't know if they were advertising it so much yet or what. So I just.
I just have several patients there that had become an on-site care. So after respite care for 5 days ends, and there is no place for the family or patient to be able to take care of after that, and they opt to stay at the inpatient unit, but it has to be paid by out of pocket. And they can stay indefinitely. But the different.
So I think there's some expectation that it's not going to be. I mean, again, you're looking at what the hospice expectation would be. So it's not like you're going to move in and anyone thinks you're going to be there 2 years. That's not going to happen. But so there's still some kind of criteria before they offer that to you. But yeah, it's a great thing because if you can't take them home, you can't take the patient home, then you take them to an ECF, or you take them to, you let them stay at our inpatient unit. And our inpatient unit, like I said, if you haven't seen it, you should see it. It's beautiful. And our nurses, the ratio of our nurses to patient is, you can tell me more than that, 4, maybe 3 or 4 or 5 to 1. And in an ECF, it's much, much higher. So the care that you get is really good. So.
Time for one more question. Is there one? Please join me in thanking Sue